right. Well, we're going to get going here with our presentation. Just wanted to welcome you all to this latest edition of our Performance Improvement Bootcamp that we're hosting. And we get the privilege of learning more about the 340B program today. Looking forward to learning more about it. And we have Nate Aurich from Pillar Health, who's going to be leading this presentation. He's a 340B expert, and so looking forward to hearing what he has to share. If you do have any questions throughout the presentation, please feel free to utilize the Q&A buttons to the bottom of your screen. It should be showing up just slightly to the right of center from your view. We'll be monitoring that throughout. But with that, I will hand it over to Nate.
Thanks, Wade. Good morning, everybody. My name is Nate Aurich. I'm the VP and Managing Director of Pharmacy Development at Pillar Health. Great to have the opportunity to speak with you all this morning. Let me just throw my slides on the screen here. Hopefully everybody can see that. So as I mentioned, my name is Nate Aurich. My background is in health system outpatient pharmacy. I spent about 20 years working for an academic health system in the Vermont and New York area. And over that time, had the great opportunity to lead 340B programs, to build retail pharmacies, mail order pharmacies, an ambulatory infusion center, and then a large and fairly successful specialty pharmacy enterprise. And I have taken a lot of lessons from that into the world of strategy, advisory, and consulting. So I'm fortunate today to have the opportunity to provide an overview of the 340 program for you, and then to dive into some of the threats and opportunities that are facing hospitals and providers across the country around 340B. So our agenda for this morning, we'll start with a fairly high-level overview of the 340B program. We'll look at some of the basics, and then I'll share some additional resources for folks who want a deeper orientation to sort of the fundamentals of 340B. I'll review recent developments, including legislation at the federal and state level, ongoing litigation around 340B, and regulatory action. We'll talk about optimization strategies that hospitals can use in different contexts of 340B. We'll look at in-house pharmacies, including retail and specialty pharmacies, and understand a little bit better about what's involved in capturing and maximizing the opportunity we get from in-house pharmacies. And then I'll talk about emerging trends, including infusion, telehealth, specialty pharmacy, and in several other areas. I do have some poll questions, so hopefully I'll put this on the screen, but hopefully we are able to actually deliver the poll question. Oh, I see it on my screen. So we'll give people a minute or two to answer these questions. I just would like to understand a little bit better who we have with us today, what your role is, what type of organization you're from. We're expecting it's mostly senior hospital leaders. Let's see. Primarily critical access and sole community, largely C-level leaders. Great. Well, folks can feel free to answer this question in the next couple of minutes, and I will dive right in while we're waiting for that. So what is 340B? Many folks probably have at least the basic understanding of what 340B is. It's a drug discount program. It's mandatory for pharmaceutical companies who want to have their drugs be reimbursable by Medicare and Medicaid. But I'll talk a little bit more about some of the sort of the key details. So this program has been around since 1992. It was established, as many federal programs are, as sort of a backdoor funding mechanism for hospitals who had imposed requirements for care, things like MTAL and other mandates that safety net providers had to provide care, but those mandates were not funded. So 340B was among multiple different attempts by Congress to provide sources of funding to those same types of safety net institutions. To be eligible, an entity has to meet certain criteria, and the type of criteria varies by the type of entity. In 2010, the Affordable Care Act expanded the types of entities that can participate, but hospitals primarily have to either have a statutory eligibility like a critical access hospital or meet a disproportionate share requirement. That disproportionate share reflects the burden imposed on those hospitals by under-reimbursed or uninsured patients. The formula for that is here on the right. I'm not going to read that formula, but for anyone who's curious about the nerdy details, that's what that formula for the DPP looks like. Looks like since most folks are critical access or sole community hospital, critical access hospitals, as I mentioned, are eligible by statute. Sole community hospitals have to meet an 8% DISH percentage, and disproportionate share hospitals, children's hospitals, and freestanding cancer hospitals have to meet an 11.75% requirement. All of these hospitals must be either nonprofit or publicly owned, and nonprofit organizations have to have a contract with a government entity, a state, an agency, et cetera, to provide safety net care, meaning they have to care for patients whether they can pay for that care, whether they're insured or not. Once entities participate in 340B, they get access to discounts. It looks like hopefully the graphic is lined up properly on your screen because it isn't perfectly lined up on mine. That discount is based on a statutory formula called the ceiling price. And there's lots of moving pieces in the ceiling price. So in general, the value of that discount is between 30 and 60% of the cost of the drug at the wholesaler acquisition cost, which I usually think of as the sort of the Amazon list price, before they slash it in half and pretend that there's a big discount. But it can be much deeper than that. So there are penalties built into the pricing mechanism that in some cases result in the price of a drug being dropped to a penny. We call those penny prices. Sometimes you see drugs where their WAC price is $20,000 or $30,000 or more, where the 340B cost is only a penny or 10 cents or 15 cents. These discounts are intended to support the safety net mission of the organization. The exact language in the statute or in the Federal Register notice is to stretch scarce federal dollars to provide care to indigent patient populations. It is not explicitly intended to provide patients with access to discounted drugs, although some entities have chosen to do that. The discounts apply only to what we call covered outpatient drugs. So that means, first, obviously, the drug has to be used in an outpatient context, and it has to be a type of drug that the statute applies to. The covered outpatient drug is defined in the Social Security Act, and it excludes certain things like vaccines, supplies, devices, and other items. There may be discounts on some of those items that are available that are similar to 340B discounts, and we'll talk about that in a few minutes. But in general, these are only drug items and only those used in an outpatient area or for an outpatient in a mixed-use area. Those entities that received access to the 340B program in the 2010 Affordable Care Act did so with a restriction called the orphan drug exclusion, and I'll talk about that a couple more times over the course of the presentation. But essentially, manufacturers are not required to offer discounts to those types of entities on drugs that are intended to treat a disease that has an orphan designation. This graphic gives you a little bit of a sense of what these discounts look like and how they work. The insurance reimbursement is generally couched as a percentage of the average wholesale price. No one really pays the average wholesale price for anything. It's a benchmark price that we use for calculations. And that insurance reimbursement is usually very close or slightly above the wholesaler acquisition cost, which is the typical price before GPO contracts or other discounts. That wholesale acquisition cost is somewhat higher than the average manufacturer price. The AMP is a factor in reimbursement in other contexts, and the 340B ceiling price is a significant discount. Here, we're looking at about a 40% discount. Again, that discount can be between 30 and 60% or as high as 99%, depending on the circumstances. Beyond the eligibility of a hospital, one of the key factors in the 340B program is the definition of a patient. And there has been a fair amount of litigation over this, so I'll describe that in a few minutes. But the definition of a patient is that the covered entity has to have a relationship with the patient where the covered entity is responsible for the patient's care and maintains an ongoing medical record of that patient's care. There are some ways to include in that patient definition types of care that are being delivered by other providers, not specifically employed by your organization. So the language here is under contractual or other arrangements, e.g. referral for consultation. And there is a fair amount of opportunity for covered entities to capture 340B benefit for care that is provided by unaffiliated specialists or specialists with whom there's a contract, but not a direct employment relationship. There are some exclusions. So HRSA has long held, and HRSA is the regulating agency, in this case, Health Resources and Services Administration, they have long held that care does not include diagnostic testing, so imaging, et cetera, or the administration of a drug alone. There are some additional requirements for HRSA grantees. I won't go over those in great detail because it looks like there's primarily hospitals here. I think I'm going to click on this share results button, and hopefully that will flash it on the screen for everyone. So 95% are critical access hospitals or sole community hospitals. There was one representative of Dish Hospital here, one representative of a hospital that's not 340B eligible. 51% are C-suite leaders, 13% are VP or director or clinical leaders, and there are some pharmacy directors, 340B leaders, and several other folks who don't fit into either of those categories. So I appreciate everyone sharing their responses, and I will click the stop sharing button. Over the last 3 years, we've seen a lot of growth. And in fact, throughout the history of the 340 program, we've seen steady growth, but that growth blew up in 2010. There were several major changes in 2010 that resulted in more entities getting access to more 340B discounts in more contexts. And so right up until 2022, 2023, we saw really steep growth in the volume of 340B purchases and the value of those purchases to covered entities in terms of savings. Unsurprisingly, the larger the 340B program is, the more strenuous the resistance has been from the pharmaceutical industry. And we'll talk a little bit more about that in a few minutes. I will say here, and I'll come back to this as well, that multiple contract pharmacy arrangements were new around the time of the ACA in 2010. Historically, HRSA had multiple demonstration projects that allowed entities without a pharmacy at all to sign contracts with a single pharmacy for the purpose of accessing 340B savings for those patients. In 2010, HRSA took the limits off those, and so there are now no restrictions on how many contract pharmacies a covered entity can contract with for the purpose of accessing 340B. 340B comes largely in two big buckets. Those are mixed-use savings and retail pharmacy. Retail pharmacy includes both pharmacies that you own and pharmacies that you contract with. Mixed use is a term that refers to areas of the hospital that can be either inpatient or outpatient. An example would be an emergency department or other areas, day surgery, et cetera. So in this case, these are direct savings on the cost of the drug that are being administered to patients. This is an area that generally composes more than half of the total savings for most hospitals and other 340 types of covered entities with significant infusion and other administered drug volume. It can be really tricky to make sure you're capturing all the value. So while a large portion of traditional 340B savings comes from contract pharmacy, I think most 340B leaders would agree that they spend a disproportionate amount of time solving problems that occur in data and operations in the mixed use area. And there are a fair amount of opportunities for entities that haven't invested that time yet to grow the value of 340B in this mixed use area. Retail pharmacies, not all entities own their pharmacies. Most entities at this point have contract pharmacy arrangements. Many have dozens and dozens or even hundreds of contract pharmacy arrangements. In these cases, you sign a contract with an outside pharmacy, a chain, a CVS, or an independent in your area. And when a prescription is filled at those pharmacies for your patient, you take on essentially the responsibility for that prescription. The pharmacy sends you the revenue that they receive from both the patient and the patient's insurance company, if there is one. You replace the drug they dispense with a drug purchased at 340B. You pay that pharmacy a dispensing fee, and then you keep the remaining value, the difference between the reimbursement for the drug and what it costs you to pay the pharmacy and the drug. And again, I'll reiterate that feel free to put questions in the chat or submit them through the Q&A. And Wade and the staff at Stroudwater will pause, and I'm happy to answer them at any time. I will leave time for questions at the end of the presentation, but if I get 20 slides deep and you feel like you don't want to bring the crowd back to the questions, feel free to just throw it out whenever it pops in your mind. There are certain elements of the 340B program that every covered entity needs to have in order to successfully manage their program. The first is a third-party administrator. There are many third-party administrators out there, and most 340B covered entities at this point are working with at least several. Some of the big vertically integrated payer pharmacy organizations have their own owned TPA and require that you use their TPA. CVS owns WellPartner. Uh, ESI, Cigna, also known as Evernorth, owns Verity. Walgreens has its own TPA. So you don't necessarily have choices for all your contracts on which TPA you use, but where you do, you select your own TPA. And this TPA manages the bulk of the day-to-day labor involved in operationalizing the 340B program. They manage your virtual inventory. So as your contract pharmacies or your mixed use areas dispense drugs in, you know, increments that are less than a full bottle, you accumulate those until they reach full package sizes that can then be purchased at 340B. The TPA also will send invoices to the pharmacies. They'll send purchase orders to your wholesalers. They'll track all the data and they maintain your auditable records. They are looking at all the dispensation records, comparing them to your medical records that you provide them through your EHR, determining eligibility on a record by record basis, and then retain all that information for you so that in the event of an audit, you can provide that to a HRSA auditor. A 340B manager is an internal resource. I have worked with a lot of covered entities over the years that didn't have a dedicated 340B manager. Sometimes it's the pharmacy director, sometimes it's a pharmacy technician, sometimes it's someone in accounting, finance, or compliance. In either case, you need someone whose responsibility it is and who has the capacity to manage the 340B program. And at a minimum, those folks are identifying opportunities for 340B savings, managing relationships with vendors, including wholesalers, third-party administrators, contract pharmacies. They're arranging your internal compliance processes. So there should be a compliance committee. There's a policy procedure document that you need to maintain. You may do an annual external audit, and your 340B manager is responsible for all of those functions. For those of you who are CFOs, if you're a CFO and you're managing the 340B program directly, you should probably give us a call because I think we can help you out. In general, when I've seen that, it suggests that there's opportunity that someone who has so many other demands of their time is just not necessarily able to fulfill. So we'd love to help you out, and you might want to consider finding members of your team who can dedicate a significant proportion of their time on a day-to-day basis in managing the program. The last is an external auditor. And of course, there are other folks, whether you have a compliance consultant or organizations that provide technical assistance in other discrete areas of 340B. But HRSA does have an expectation that covered entities with a contract pharmacy program engage in an annual independent audit. This is not a regulatory requirement, but what they say is that in the event of an audit from HRSA, it demonstrates good faith effort to manage the compliance of the program. And if you don't have a record of a recent external audit at the beginning of a HRSA audit, they tend to take a much deeper dive into your program, and the scrutiny tends to be significantly more intense. Those are really the highlights of 340B fundamentals. I have included here, and when we distribute these slides, you can click on these links, resources that I've found to be helpful over the years to help access greater detailed information. You can use some of these resources to help train your staff. I particularly recommend the Apexis 340B University. The prime vendor is a government contractor, so HRSA contracts with Apexis to provide compliance resources, training, and other functions for 340B covered entities. There are two versions of this Apexis 340B University. They're both online. The initial version is free. It takes a few hours to go through. It gives a really good grounding in the basics of 340B. So if you're onboarding new personnel in finance or compliance or revenue cycle management, it can be really helpful to establish a shared baseline of 340B knowledge by using that initial 340B University orientation. And then there also is a certificate program. So if you have a 340B leader, director or manager, et cetera, who needs a deep grounding in 340B, the certificate program can be great for that. Other organizations I listed on here, HRSA, of course, has a fair amount of resources itself. The 340B report is a great resource for developments in 340B, and they also can help bring to your attention new developments around vendor services, emerging trends. We'll talk some about those emerging trends towards the end of the presentation. NRHA has a great advocacy portal. There's a lot of opportunity for advocacy around 340B. If you haven't engaged in advocacy in your state for 340B, I strongly recommend it. There are a lot of threats, as we'll discuss in a few minutes, to the 340B program and its value for covered entities. And the best way to push back at that right now is to engage in state level advocacy. For those of you who are members of 340B Health, 340B Health supports a lot of those advocacy efforts. They will also join you in Capitol Hill Days. They do a lot of research. They have 340B Coalition events twice a year. So that is an organization that I strongly recommend you familiarize yourself with if you're not already members. So we'll move on to recent developments. I'm going to go through these relatively quickly. There have been a lot of key regulatory developments over the last 15 or so years. And a lot of these developments have had a major impact on how we manage 340B and the value it brings to our covered entities. So the first I'll mention is the Affordable Care Act. As I discussed earlier, it established new types of covered entities that can be eligible in the 340B program. Critical access hospitals, sole community hospitals, those are examples of those newly eligible types of entities. It did impose the orphan drug exclusion on these entities. I'll discuss a little bit more what that means in a few minutes. In 2014, the first major challenge to HRSA's regulatory authority came in a lawsuit from the pharmaceutical industry over how HRSA was interpreting this orphan drug exclusion. HRSA's interpretation had been fairly light and in a way that allowed Medi-covered entities to still access discounts for orphan drugs when they were not being used for their orphan indication, which is quite common. HRSA challenged that, and courts actually ruled against HRSA. HRSA lost that lawsuit, and it lost several subsequent lawsuits over the scope of its regulatory authority under the 340B statute. In 2020, Arkansas had a lawsuit against the Pharmaceutical Care Management Association, the PBM trade association, around rules that it had issued regulating the pharmaceutical benefit management industry in Arkansas. And this is tangentially related to 340B, but becomes very important because it was the first example of major interference by states in how these federal programs can be regulated. It tested the concept of federal preemption, and I'm not an attorney, so this is not legal advice, and I would encourage you to speak to some of your legal counsel in greater detail if you're interested. But it tested this concept of preemption under federal law, particularly under ERISA, which regulates retirement programs, but it emboldened states to engage in regulation in areas that had historically been considered the sole purview of the federal government. And in subsequent years, this became really relevant around contract pharmacy, and a lot of the litigation around contract pharmacy fell in states' favor along these same lines. So as HRSA lost more and more lawsuits around its authority to regulate the program, to issue binding regulatory guidance, the pharmaceutical industry, starting in 2020, took that window to refuse to adhere to HRSA's interpretation of how contract pharmacy implementation should work. And they started restricting access to contract pharmacy discounts. That has had a major effect on the 340B program, as I'm sure many of you know, and I'll go into that a little bit more in a few minutes. So in more recent years, and particularly around the Genesis ruling, we've seen a fair amount of activity and changes in how 340B programs are conceived and how they're operated. The Genesis ruling questioned HRSA's enforcement of the 340B patient definition. And this was a little bit of a mixed bag for us. I'll talk about the Genesis ruling in more detail in 2 slides. But I think that there has been a lot of mixed feelings in the last 10 years or so around HRSA's enforcement, because some of the guidance it issued, we had a lot of objections to, and we thought were quite onerous. And so we were initially relieved that courts were saying that HRSA's more strict interpretation of these rules couldn't be enforced. But then we discovered that if HRSA can't enforce its rules, that applies equally to the pharmaceutical industry. And so when they started interfering in our access to discounts, we had little recourse, at least in federal law. The last development that I'll mention here is that while the Supreme Court had previously struck down CMS's attempt to pay providers less for their drugs if they're 340B eligible. The basis of that ruling for the Supreme Court said that CMS essentially didn't follow the proper process. They didn't correctly survey entities to establish their actual cost, which they normally would do in other contexts. So President Trump issued an executive ruling in April, and in further legislation and in the 2026 OPPS, it's clear that CMS expects to issue a proper cost survey in 2026, and it's very likely, or at least there's a great deal of concern over the likelihood that that will lead to CMS reissuing its reimbursement changes to reduce the reimbursement for 340B eligible entities for drugs that are administered and billed under Part B. I see some chat messages, but I have not been paused for any questions. Okay, we'll keep going. Let's talk a little bit more about those drug manufacturer contract restrictions. So in 2020, the first of those restrictions were announced. And between 2020 and 2024, virtually every major pharmaceutical manufacturer with an agreement with CMS for participation in the federal rebate program issued similar but not identical restrictions on access to contract pharmacy 340B discounts. The theory is that the statute does not explicitly require manufacturers to ship discounted products to contract pharmacies. This will be really relevant in some of the strategies we have for getting around these restrictions. But initially in 2022 and 2021, a lot of hospitals, and I'm sure many of you included, saw significant decreases in the value of their contract pharmacy program. For many, those decreases looked like 50% or more loss in the revenue stream that you had been receiving. And for DISH hospitals with in-house retail pharmacies, according to 340B Health survey data, those losses can be as great as 90% of their contract pharmacy revenue. Interestingly, and you see this in several different data sets, the total value of 340B purchases in each year through 2023 didn't necessarily decrease. Entities have invested a lot of time and energy in finding other ways to maximize the advantage they get from the 340B program so that they can preserve the services that they have built over the years that rely on 340B funding in order to remain sustainable. I mentioned the Genesis decision, and I'll describe that in greater detail here. So in 1996, HRSA had issued its formal patient definition interpreting the statutory requirement that 340B discounts be only delivered to patients of the entities receiving the discounts. HRSA's definition includes multiple parts, and I showed that to you on the screen earlier, and all of this was challenged when HRSA applied their interpretation against an entity called Genesis Healthcare. So Genesis sued HHS. I think the beginning of that lawsuit actually came in 2017. And so this more or less final ruling in November of 2023 struck down, in this specific case, HRSA's restrictive interpretation of the definition of a patient. In this particular case, HRSA said that Genesis had to initiate the care underlying the prescriptions that were being qualified for the 340B program. So even if the prescription itself was written by an outside specialist, if that specific care had not been initiated by Genesis at an eligible location of an eligible hospital, HRSA said it can't be a 340B eligible drug. If you obtain discounts, it's considered diversion. So the court upheld HRSA's general authority to interpret the patient definition, but said that in this specific case, its interpretation was in conflict with the plain language of the statute. While the immediate effect of this ruling applied only to Genesis, and it did not constrain HRSA's ability to interpret the definition for other entities or in other contexts, many covered entities took this as an opportunity to broaden the definition of a patient in their own policies and procedures. I'll go through some of those specific strategies, but in general, we have seen many hospitals, in fact, most, find ways to relax that patient definition to reduce the likelihood of technical ineligibility, barring access to discounts where it's clear to anyone reviewing the circumstances of a particular patient that the covered entity retains responsibility for their care. I mentioned the importance of state advocacy, and this map is a great example of how important that can be. So, following the loss for many hospitals of access to contract pharmacy discounts, we spent a lot of time and energy trying to get Congress to take action. I know I went to the Capitol Hill several times. We spent a lot of time on Zoom calls during the pandemic with our federal delegation saying, you need to help us out here. This is really going to hurt our ability to serve our patients. And Congress really was completely unable to pass any legislation that would support our needs without significantly harming our interests around 340B in other ways. Additionally, while HHS has sued these manufacturers in federal courts across the country, those cases have generally not been going our way. The courts have either taken little action or ruled more or less in favor of the pharmaceutical industry's contention that the statute does not specifically require drugs to be shipped to contract pharmacy locations. I feel like, and our lawyers have always felt like, there's a decent argument to be made in under agency law that in order to effectively use the program, we need to be able to hire agents to implement it for us, including pharmacy agents. But the courts have generally not been persuaded by that. And of course, these rulings are moving really slowly. There are some rulings that were somewhat in our favor, but they have not significantly changed the landscape for access to discounts nationwide. So particularly in 2022 and 2023, we started to see many more states follow the Arkansas Blaze trail in trying to help entities in their states recover access to 340B discounts. This map is only 3 months old, but even since this map was first developed, there have been many more states that passed legislation in 2025. And that's including in Vermont, where I live, Rhode Island, Maine, Hawaii. There are many, many states now across the country that have some version of protective language around access to contract pharmacy discounts. A lot of them also prohibit discrimination in reimbursement. So there had been some PBMs that had taken action similar to CMS and said that they were going to start reducing reimbursement where there's a contract pharmacy relationship or a pharmacy is owned by a 340B covered entity. So many of these laws also have restrictions against that type of activity. And a handful have established claims clearinghouses and information requirements, reporting requirements on covered entities. In those cases, that tends to be the result of negotiation with the pharmaceutical lobby and is an attempt to introduce some greater transparency into what's happening in the program. I think most 340B covered entities are generally supportive of transparency when the metrics being reported are reflective of the way the 340B programs are implemented and the intent of the program. So we strongly encourage anyone in a state who's on here in gray who has had litigation that introduced that hasn't yet passed to get in contact with their local legislators and to help them understand the value of 340B in general and the consequences that we've all suffered as the manufacturer restrictions have reduced our access to 340B savings and benefit. Looking ahead in terms of recent developments, we have the effect of the Inflation Reduction Act coming out on January 1st. The IRA included a Medicare drug price negotiation program. And this drug price negotiation program starts with 13 different drugs, really 10 different specific agents beginning in January. And they have established significantly reduced maximum fair prices that Medicare will pay for these drugs beginning in 2026. Over the next 3 years, the number of drugs in this program will increase significantly. And the implications for 340B are actually pretty substantial. The first is that covered entities are only entitled to receive either the maximum fair price or a 340B discount, but not both. And so there's a fair amount of challenge involved in implementing that. But also because the prices of these drugs are being reduced, the value of the 340B discount is smaller than it has been. And when I say that, I mean it's significantly smaller. We're expecting that the 340B savings associated with Medicare Part D plans will drastically decrease between now and 2030 when the drug price renegotiation program is in full swing. And among the many other challenges this represents, especially for those entities with an in-house pharmacy, Medicare Part D, being an annual and provider program, had often been the largest aggregate source of 340B related margin from an in-house pharmacy and from contract pharmacies. So everyone needs to factor into their planning the fact that it's likely that the value you receive from drugs that are subject to the maximum fair price under CMS is going to continue to decrease in subsequent years. This next slide gives you a little bit of a visual of what the growth in covered drugs in this program will look like. It does not include any drugs that are administered in a clinic setting or in a hospital in 2026 and 2027, but Part B covered drugs, including infusions, will begin to be covered in 2028. By 2031, the total number of drugs covered by the program will be about 100. And we can expect that the price of these drugs will eliminate the majority of the 340B value of these products when they're reimbursed under the Medicare Part B and Part D programs. The rebate model was announced by HRSA earlier this year. For folks who aren't familiar with the rebate model, it had been a bone of contention with manufacturers for a long time that they have little insight into what's behind the 340B discounts that are being claimed. And they have often argued that there's significant risk of diversion and duplicate discounts when covered entities have essentially open access to buy 340B products on 340B accounts. They hadn't had much traction with the demand for a shift to a rebate model until the beginning of the Medicare drug price negotiation program got closer. I mentioned that there's a protection in the IRA that protects manufacturers from being subject both to 340B rebates, 340B discounts, and the maximum fair price imposition. And the government has few ways to manage the implementation of that deduplication requirement. What HRSA came up with is allowing the manufacturers that are subject to the drug price negotiation program in 2026 to propose rebate model pilot programs. And each manufacturer now has proposed their own model pilot program. HRSA established certain restrictions on these programs. They had to pay claims within 10 days. Covered entities have 45 days to submit claims for rebates. The manufacturers are not permitted to deny rebates for diversion reasons. They're only allowed to deduplicate the rebates against maximum fair price payments. There's a lot of information that we don't have about the nature of these programs and how it will be implemented because HRSA was expected to issue its approval of the submitted pilot proposals on October 15th. Because the government has been shut down, the employees at HRSA who are reviewing these proposals have been furloughed. So we really have no information about what progress was made around reviewing these programs or what HRSA's plan to implement starting January 1st looks like. It is possible that implementation of the program may be delayed. It's not likely that the program will be canceled or that the pilots will not go live in 2026 because, as I mentioned, the clearinghouse that manages this deduplication requirement relies on data submitted through the rebate model in order to protect manufacturers from essentially being dinged by both types of programs. We are expecting that manufacturers will all hire Beacon, which is a company of the Berkeley Research Group. For those of you who are familiar with the Berkeley Research Group, you recognize them as the same parent company of 340B ESP. So it's likely that the claim submission and management process will be very similar in Beacon as it has been in 340B ESP. And we're expecting that third-party administrators will likely be able to handle the data submission and rebate reconciliation process on behalf of covered entities. But again, there's a lot of information about this that we don't have yet. What we know is that it will increase the burden of drug spending on covered entities. The biggest change here is that instead of being able to buy drugs upfront at the 340 price, you have to buy them at WAC. And then you wait between, let's call it 15 and 55 days in order to receive the rebate on those claims. And so the float, the capital cost of buying and holding onto that inventory, is borne by the covered entity until those rebates are received. We generally expect that those rebates will be available and that there will be few, if any, significant denials by manufacturers for these rebates, but nevertheless, we're on the hook for fronting the inventory costs. And for those organizations with significant capital constraints, it may involve access to credit or, in other ways, funding those purchases that carries along additional carrying costs of financing those purchases. So let's talk a little bit about how covered entities participating in the program can optimize their performance. I think we have a poll question related to that first. So we'll see if we can get that poll question up on the screen for everybody. Great, I see it. So I'm curious to know how many folks on this call are aware that their organization has a persistent and comprehensive process for reviewing the performance of the 340B program to identify gaps and opportunities. And some folks may have programs that take a close look at compliance. And in this case, I'm particularly interested in whether you have a process that help identify financial performance gaps and financial performance opportunities. So we'll give folks a couple minutes to answer these questions. So far, it looks like about half of you say yes, and about a quarter say they don't know, and the remainder say no. So that's really interesting. I absolutely urge every covered entity to have a process in place to review performance, to understand whether we have additional opportunity that we're missing, and to really plan for going after that. And I'll talk a little bit about what that looks like while that poll is still on the screen. So contract opportunity surveillance. It sounds intense and fancy, and it really isn't. The simplest way to do that is to take all of your outgoing electronic prescriptions, dump it into Excel file, and create a pivot table of where those prescriptions are going. This is sort of step one. And as you look at the top 10 list or so of where those prescriptions are going, the question you're asking is, are any of these receiving pharmacies not in our contract pharmacy program? I would suggest people do this on at least a quarterly basis. It depends on your resources. So if you can't do it quarterly, absolutely suggest you do it at least once or twice a year. There are changes that occur in the pharmacy industry, changes that occur in patient behavior, new services that attract patients to move from one pharmacy to another. There have been a lot of closures of pharmacies nationwide in the last couple of years. So that is always happening in the background. And it's easy to miss when there's a pharmacy who ought to be in your contract pharmacy program and isn't. And that can cost significant opportunity. And one thing we know is that there are relatively few costs for keeping a pharmacy in your contract pharmacy network. But if it's not in your network and you come to discover that it should be, you can't go back and recapture any of that opportunity that's previously been missed. I also recommend regular intervals for reviewing some of the key data elements in 340 programs that drive performance. The first is location mapping. So your TPA will take a map from you of all your locations, everything that you have in Epic or your other EHR that says, here's a location where patient care may occur. And that map has to identify whether those locations are 340B eligible or not. There can be a lot of factors behind maintaining that mapping. And sometimes when we develop it, we may make mistakes or we may miss certain things. And so best practice is to look at that at least once a year, if not more often, and make sure that it's being transmitted appropriately, that it's constructed accurately, and that it's fully up to date. As you review it, you may also consider if there are locations in your location map that are ineligible, where there's significant prescribing, dispensing, or administration activity. Are there things that we can do to change the eligibility status of that location so we can go after the 340B benefit that's locked behind its ineligibility? Provider files, the simplest starting point for capturing 340B eligibility is identifying prescriptions that are written by your employed providers. However, identifying employed providers can be somewhat complex. Are we looking only at full-time providers? Do we include per diem or locum doctors? Maintaining that provider file in an accurate and up-to-date manner is really, really important. And there can be garbage that creeps in. If you're using a script to combine your credentialing file with an employment file to help you identify those credentialed providers that are 340B eligible and to pull the different data elements from more than one system. Those processes can break down. There can be IT errors. There can be system changes in the background. So we want to make sure on a monthly basis, we're keeping an eye on our provider file so that we're not missing eligible transactions either at our in-house pharmacies or at contract pharmacies that we should be capturing because of problems within our provider file. Eligibility logic refers to the configuration settings we've chosen with our third-party administrator, and that's true for both mixed-use areas of the hospital, outpatient clinics, and contract pharmacy. We make certain decisions like, for an eligible patient, how long can it be since the last time they had an encounter? I mentioned that a lot of entities had made their policies more flexible after the Genesis ruling around the patient definition. And this is an example where if entities had a window of eligibility that lasted for 12 months after the last encounter, many of those increased that window from 2 years or even to 3 years to say, just because the patient hasn't seen us in the last 12 months doesn't mean we're not still responsible for the care that they're receiving. We may still have prescriptions that we're sending to them when it's time to renew them. They may have questions that are coming through my chart or something similar. They're still our patient, even with that window in mind. There are lots of other configurations around the types of drugs that are eligible, how we look at specific locations. So it's important to have a decent grip on the logic your TPA is using to determine eligibility and to make sure that's consistent with your policy procedures and that you're not missing significant areas of opportunity. I mentioned reviewing, invoicing, and purchasing activity. Just like any other area of a business, we want to make sure we have a good grip on what's happening in the business. Anytime you see significant volatility, the number of claims being qualified decreases significantly, the number of purchase orders or the size of those purchase orders changes unexpectedly. Those are cues that something in the background has broken down. This sounds like if everything's working properly, it shouldn't happen. But unfortunately, it happens a lot, especially when most covered entities are using multiple TPAs. These are complex integrations to maintain with your IT systems. Things can break. Wholesalers can make errors. Your TPAs can make errors. Your IT department can change things in the background without realizing the downstream effects. So it's really important to keep an eye on pharmacy invoicing, purchasing activity going to your wholesaler, et cetera, to make sure that nothing is changing in a negative way. Even if you were to see a significant one-time increase in purchasing, that's not necessarily a good thing. It can indicate changes in how the processing of the program is functioning that can expose you to diversion risk. And then market trends. So in the last 10 years, we've seen major changes in the nature of the relationships between covered entities and contract pharmacies and TPAs. Big changes in how much we pay them and how we pay them, in other terms, how the contracts are established. Winners only is a common one that refers to logic in these contracts that say a claim is only qualified at a contract pharmacy as 340 to be eligible if both the covered entity and the pharmacy makes money that way. That language is not necessarily advantageous to you because in general you make money on almost all claims. It will limit the number of claims flowing through, and it often reduces the contract to a largely brand only contract. But there can be some circumstances where it's valuable to impose that type of restriction. NDC exclusions are really growing, and we're expecting that to sort of explode now with the IRA. The early feedback from major contract pharmacy chains and big mail-order and specialty pharmacies is that they may carve out drugs that are subject to the IRA maximum fair price caps from your 340B program. So we're expecting to see those first 13 drugs excluded from many contract pharmacy programs starting at the beginning of the year. But there have been NDC exclusions in many contracts for a long time, and sometimes covered entities have those in the agreements or they're under the control of their contract pharmacies without really knowing what it is that's being excluded. Those exclusions are always subject to negotiation. So if you see that some high cost, high value drugs are being excluded in your contract pharmacy arrangement, potentially without your permission, you may want to go to your pharmacy partner and say, listen, What's the barrier here? Maybe you're making more money on these. Maybe we need to pay you a little bit more than we're paying you on other drugs, but we still want to include these in our 340B program. And the last that I'll list here on this slide is submitting electronic prescription data to your third-party administrator. Historically, a lot of covered entities implemented qualification logic that relied on encounter data, as well as hospital ADT data, drug dispensing and administration data that comes from Pyxis machines, et cetera. There is a lot, like a great reason, a lot of great reasons really for submitting your electronic prescription data to your TPA. And in fact, many covered entities have really successfully transitioned to using electronic prescriptions only for qualifying your 340 eligible transactions at contract pharmacies. They're generally, you might miss some opportunity by not having encounter data flow to your TPA for these arrangements, but we capture more by having ERXs in there, and it also creates fewer moving pieces in the program that can fail. So it tends to be a more reliable method for determining eligibility at the contract pharmacy level. I mentioned 340B ESP a little while ago. 340B ESP is the company established and contracted with by pharmaceutical industry to manage their contract pharmacy restrictions and the policies they've imposed. So in general, because they still need to provide some access to contract pharmacy pricing for those entities that don't have a pharmacy, all of the policies have had exceptions that they've implemented in different ways for how covered entities subject to these restrictions can access 340B discounts. And this is a largely hospital crowd, but those restrictions are also implemented very differently for non-hospital 340B eligible covered entities like federally qualified health centers, Ryan White programs, and other types of HRSA grantees. So 340B ESP is the clearinghouse for managing this. To get access through these exceptions, covered entities have had to submit claim data. Back in 2021, there were a lot of anguished debates within covered entities about whether we should agree to share this data with the pharmaceutical industry. How will they use it? Are we capitulating to their strategy here? Are we putting patient data, privacy, and security at risk, et cetera? At this point, most, if not virtually all, covered entities have agreed to submit data to 340B ESP to restore access to the extent it's possible to contract pharmacy discounts. In general, the exceptions we're looking for are where manufacturers allow us to designate specific pharmacies where discounts can still be accessed. In most cases, this happens if you don't have a pharmacy, but some manufacturers with a lot of specialty drugs will allow you to designate drugs, designate pharmacies where you can access high-cost drugs, drugs within a specific portfolio. Some of them have policies that say you can designate pharmacies within a 40-mile radius around your covered entity, and you can designate more than one. So of all the manufacturers participating, there are many different ways that their policies are being applied. And all of these are managed through ESP. So it's important to spend time and energy in maintaining high quality integration with ESP. We want to make sure our data is coming across, that it's clean, that it's persistent and consistent, so we're not missing data delivery opportunities. Your TPA may be managing this for you, but your covered entity is still on the hook if data doesn't come across properly or it's missed or deficient in some other manner. It's also really critical to manage the designations. So you can pick these pharmacies where you can get access at a manufacturer by manufacturer level. And to do that, what you want to look at is which of the pharmacies available for designation are processing the greatest number or the highest value of prescriptions for each of these manufacturers. That's a fair amount of effort to do. Your TPA may help you with it, but it's important to do it because it's the best way to preserve and extract the maximum amount of value from 340B and from the opportunity to use these exceptions for as long as they exist. Once we've made these initial designations, oftentimes we're allowed to change these designations at specific intervals every 6 months, every year. It varies by manufacturer. But volume will shift for these specific products, and the mix of products will shift over time. So it's important to always be confident that we have made the proper designations for each manufacturer to avoid missing any opportunity for 340B savings that might be available to us. Referral capture, I mentioned earlier with the definition of a patient that there is language that says it has to be your patient, your provider, or through a contractual relationship, including referrals for consultation. So this can be hard to operationalize, and most of us have to contract with a third-party administrator in order to find ways to identify those prescriptions that may be qualifiable for us under this referral logic. In general, it looks like taking either a patient census or an NPI list and saying, this prescription wasn't written by one of our doctors, but it was written by for one of our patients, a patient who's had encounters with us, who is seeing our other providers. And then we have to then go into our EHR and say, do we have any evidence or any documentation that there is a referral that exists between our organization and the prescriber who wrote this prescription? Referrals can look like a lot of different things. It varies depending on EHR. It varies depending on physician practice. Sometimes you have a referral window where you can look at. Sometimes providers don't use that window as much as they ought to, and it's in the notes either of the encounter, or it could be in notes of prescriptions or other things. So it can be a somewhat manual process on a patient-by-patient basis to determine whether there is a referral opportunity to qualify some of these prescriptions. For most covered entities, that means that we use tools or services to help identify high value referral opportunity and go through that confirmation process. You might outsource it. Your TPA may offer a pharmacist or a tool that helps look for those referral notes. But the opportunity here is pretty significant. The drugs that are prescribed on a referral basis tend to be higher cost. That's where you find a lot of your specialty drugs. So it's important to look at that, to understand the opportunity you may have around referral capture, and then find the model for implementing referral capture that makes the most sense for your organization. Alternative distribution models is a way around the manufacturer restrictions. I mentioned earlier that the logic of manufacturers who sued claiming that they aren't obligated to deliver 340B discounted meds to contract pharmacies. So that's their contention in their lawsuits. So alternative distribution involves having covered entities ship the drugs to the covered entities, inpatient or outpatient pharmacy, and then having the entity's own pharmacy redistribute that medication to a contract pharmacy. Thereby, we go back to being able to ship contract pharmacy discounted drugs to these pharmacy partners, and we can recover access to those discounts. It can be logistically complex. Often it involves shipping significant amounts of product to your pharmacy and then redistributing it, something that pharmacies are generally not in the habit of doing. There may be regulatory requirements in your state. You may have to license your pharmacy as a distributor or a wholesaler, and you still have to adhere to other federal and state laws, including DSCSA, the Drug Supply Chain Security Act. That act, among other things, requires that the end recipient of the drug receive electronic information that tracks the pedigree of that drug from the factory at the manufacturer all the way until the last pharmacy receives it before it's dispensed. So as you're shipping drugs from your pharmacy to a contract pharmacy, you must be able to provide that pharmacy with that track and trace pedigree data. Some contract pharmacies have found ways to make this really easy for you. So some of the bigger mailer pharmacies like Accredo or CVS Caremark will even send a courier to your hospital to pick the medication up and then bring it back to their pharmacy so that there's less burden on your pharmacy for managing that. But the value of ADM is such that it's really appropriate for covered entities to consider sometimes significant investment in space and staffing in order to access ADM. If your organization has lost 10 or 15 or 30 or 50 or $100 million a year through these contract pharmacy restrictions, and I've seen every single one of those values and higher, spending an extra $200,000 or $300,000 a year, plus maybe $500,000 in space renovation in order to access recovering a majority of those lost discounts is a really worthwhile investment. It's a great ROI. You may need help from consultants or other folks to help you plan exactly how to do it, but it's well worth investigating and something that many hospitals, particularly larger hospitals and health systems with more human resources, have invested in over the last several years. I'll talk about some optimization practices for mixed use I mentioned that mixed use is an area of greater complexity. There's a lot of different types of data. In a contract pharmacy, all the data looks like exactly one thing. Electronic prescriptions are very standardized. Pharmacy claims are very standardized. So managing that type of the program is relatively straightforward in comparison to looking at multiple different types of dispensation data. Many entities use charge data to accumulate 340B eligible dispensations, but there are lots of types of drugs that aren't charged or they're not separately charged. They might be kit meds, they might be bundled in an APC. The the drugs themselves may be relatively low cost or used in a procedure where the drugs are not charged at all. Or sometimes we have old school methods of charge capture that revolve around paper charge tickets, and it can be difficult, if not impossible, to capture those paper charge tickets in a way that filters into the 340B program. So understanding where the data is coming from, and I've seen really, really wild data integration maps for how many different types of data sources there are and where they're going. But understanding how that's working is really important to make sure that you're getting the maximum value out of the mixed use part of your 340B program. And it's particularly important around infusions. This is often the single largest area of opportunity for any covered entity in the 340B program. But the types of data that come out of infusion operation are not always well suited to easily capturing the relevant pieces of data that are useful for 340B. So identifying those data flows, understanding how your TPA is using them, making sure that you're capturing everything in your virtual accumulator, really, really important to maximizing the value of 340B in these mixed use settings. There are certain specific types of data uses that can change the value of 340B. So any patient who's an outpatient is eligible for a 340B product until they're no longer an outpatient. So if they're admitted, the outpatient part of their stay can still receive 340B eligible drugs. Once they're discharged, any prescriptions they take home with them, those are all obviously considered outpatient. But how you operationalize that can be tricky. How you're managing the change in status, how those date stamps are established in your medical records, what they look like from a billing perspective. You can sometimes retroactively bill on an inpatient basis for drugs that are administered to a patient while they were outpatient, but you want to have in your P&P documents clarity around, are you capturing 340B discounts for those OP administered drugs, even if the billing status of those drugs may change subsequently, and how does all that work? Certain really nerdy elements like charge on administration or charge on dispense interact with timestamps around inpatient and outpatient status. So if you're charging on administration, but all those administrations are booked at midnight, you may miss opportunity or capture opportunity improperly because the actual time of the change in outpatient status may be something different. Price verification for 340B and GPO. I can't tell how many times I've seen wholesalers and manufacturers make errors in how we get access to pricing. And that can be 340B ceiling pricing. It can be direct negotiations around sub-ceiling prices. It can be accessing GPO contracts through Vizient or Premier or direct market share agreements with manufacturers. Even when you have a contractual or statutory access to those prices, it doesn't always mean those prices hit your wholesaler account. This is true both on your own 340B accounts and on your contract pharmacy accounts. I have done contract consulting work for major wholesalers, and some of you may have seen a couple of years ago, a major wholesaler accidentally disabled 340B pricing for hundreds and hundreds of hospital entities nationwide for several months. And it took probably 5 weeks for people to actually identify that it was happening. And then it took another 60 days or so for the wholesaler to fix that problem and to issue the appropriate credits. When it happens on a large nationwide scale, eventually it gets caught and fixed. But when it's happening only to your covered entity or only to a subset of accounts, you may not notice it, or you may not notice it until it's been happening for a long time, and then it can be difficult to fix. There is one really routine area where pricing falls off. 340B prices are issued to wholesalers on a quarterly basis, but manufacturers don't always have those new prices to the wholesaler on the first day of each quarter. It may come in a week late, it may come in 2 weeks late, or sometimes even longer. In that period between when the last quarter ended and the prices for the new quarter have arrived, you may lose access to those discounts, even on your 340B accounts. So you're buying drugs in your 340B account, you're expecting the discounts to come through, but you're actually paying whack for those drugs. And there's no indication necessarily in the invoices or any other part of the TPA implementation system that the prices you're paying are incorrect. So it can be really important and really valuable to monitor the pricing activity on all of your accounts. And then the last is a contract opportunity. So you have statutory access for specific drugs to the 340B ceiling price, but that doesn't mean that's the only opportunity for discounts related to 340B covered entities. With manufacturers, many of them will make sub-ceiling contracts available. That means if you sign a contract related to market share, they will offer you 340 pricing that's lower than the ceiling price, and sometimes significantly so. There are also manufacturers that offer you 340B-like pricing for drugs that you don't have statutory access to. That might be orphan drugs, it might be devices, it might be non-drug items like contrast media. There are 340B-like prices available on things other than drugs. Sometimes I've seen 340B prices available on beds and major pieces of equipment, and it's just a way for those manufacturers to attract 340B eligible entities into purchasing their products. So there's a fair amount of surveillance that goes along with identifying these opportunities. Sometimes you need to reach out to manufacturers with whom you have a significant spend to ask them if they have advantageous pricing available. You can also work with your wholesaler. Cencora in particular, but Cardinal as well, have a fairly active team involved in securing orphan drug 340B-like pricing contracts for their entities that are subject to the orphan drug exclusion. So this can be a significant area of opportunity for many entities. We're at a little past noon, so I'm going to try to speed up here a little bit. Here's our last, before I'll flash up our previous results. I may have neglected to do that. So this is poll question number 2. Do you perform persistent, comprehensive review of your program performance? Half say yes, and about a quarter say either they don't or they don't know. So if we can get this next, there we go. Questions about in-house pharmacy. Do you have a pharmacy, and do you know what proportion of the prescription area providers are coming to your owned pharmacy? So we'll give people a few minutes to answer those questions as we dive into entity-owned pharmacy. So historically, it's been the largest hospitals and health systems that are owned pharmacies. This survey data is from 340B Health. It's dated now. It's from 2021. A significant number of hospitals have opened pharmacies since then. But it makes it clear that the larger hospitals are much more likely to have their own retail pharmacies than the smaller hospitals, even though there is still significant opportunity for essentially any hospital in 340B. And it's the surest, best way to protect yourself against future encroachments on the 340 program from manufacturers and other sources. The statute has always explicitly said that covered entities are entitled to the discounts when they're buying the drug. So as long as you have your own pharmacy and you can dispense to your own patients, it's very unlikely for you to lose access to that stream of discounts. Let's see, how are we coming along on our responses? So great. So far, about 42% of all respondents have their own pharmacy. For folks who, about 30% don't know their own capture rate, and 45%, 9 out of 20 respondents so far say that they think their capture rate is greater than 50%, which is great. Let's talk a little bit about capture rates. So when we say capture rate, what we're referring to is the proportion of all these prescriptions that your providers are writing that come to your pharmacy or to your contract pharmacy. And I've got some different types of capture rate targets and measurements here on the screen. We measure this in different ways because different types of capture rates have different implications for your performance. Looks like hopefully at least the results for that are published on the screen. So appreciate everyone responding. Overall capture rate refers to the proportion of prescriptions that are coming either to your pharmacy or to a pharmacy that you have contract with. And we usually look to see 85, 90% or higher for this value, but we commonly see values in the 60, 70% range. And we usually see that where someone isn't engaging in that opportunity surveillance I mentioned a little while ago. Internal capture rate, of course, is just the proportion of prescriptions that are coming to your in-house pharmacy. I've seen a lot of hospitals with capture rates in the 5 to 15% range. And that means that there's a significant growth opportunity for your organization to generate added pharmacy revenue and to protect that revenue and that margin from future disruptions to the 340B program. We also tend to look at specific types of product groups that help us identify the large areas of opportunity for growth. Anti-diabetic medications like long-acting insulins and other products, weight loss meds like GLP-1s, HIV drugs, those are great areas of opportunity, and there are some specific strategies that help you improve capture rates in those areas. So we always tend to measure that. And we look for 60% or greater capture rates for those high-value product groups. Especially in specialty light, there sometimes are barriers to being able to dispense specialty drugs. I'll talk a little bit more about what those look like in the next few slides. But these tend to be the highest cost drugs that also have the greater requirements for high touch pharmacy service. If you can engage in this type of work, the margin opportunity is really significant. We also tend to look at, especially for smaller entities with pharmacies, uninsured capture rates and Medicaid patient capture rates. And partly this is to illustrate the varying value of different patient populations in terms of pharmacy financial benefit. Most covered entities overperform their overall capture rates in these specific groups of patients. We often are providing added service. Sometimes we give them sliding scale discounts or other things that draw them in. But these patients, while we want to serve them, and we absolutely always will, they don't generally generate a significant margin for our pharmacy services. There are lots of things that we can do to improve our capture rates. Let's see, just in the interest of time, I'm going to move a little bit more quickly here for the next few slides. We can expand our on-site infusion offerings. I mentioned earlier that infusion is a great area for opportunity for almost every covered entity. In general, infusions that are administered on site at your covered entity, either within the hospital's four walls or at a registered outpatient location, are always 340B eligible, even if the order for that infusion is written by an outside doc. So there's lots of opportunity there, and a lot of folks are working on expanding their access to infusion. I'll talk a little bit more about some of those strategies in a few minutes. Offering mail order and pharmacy and delivery services. Your in-house pharmacies are competing with outside pharmacies, chain pharmacies, et cetera. And the first thing we need to do is level the playing field. You need to be able to provide all the same services to those patients that they could get from CVS or Walgreens. They don't necessarily have much loyalty or attachment or emotional investment in those chain pharmacies, but they do want to get the services that they find convenient and valuable for them. So if your pharmacy offers all of those services, then patients are much more likely to choose your pharmacy. Another thing that a lot of organizations have had success with is non-pharmacy pickup points. So if your pharmacy is not necessarily conveniently located for all of your patients to access, maybe they come in from out of town, or maybe they have multiple locations and a lot of your patients are going somewhere where the pharmacy isn't, having additional pickup points can be really helpful in improving your overall strategy. Offering additional services like vaccine and medication therapy management, and adding specialty pharmacy capabilities are great ways to improve that capture rate and access a lot of the pharmacy services revenue that's available. Let's talk a little bit about specialty pharmacy. Specialty pharmacy is the predominant trend in the pharmacy world. It's what we spend the most of our time thinking about. It's the core of most of our strategies, and it's also the biggest threat to any organization that doesn't have its own specialty pharmacy services or ways to access specialty pharmacy, because the majority of all drugs, and I'll show you a chart that illustrates this in a second, that are being released are specialty drugs, and a major proportion and a major growing proportion of all drug spending, and in fact, all spending on healthcare nationwide, are being spent on these high-cost specialty drugs. For critical access hospitals and sole community hospitals, most of these specialty drugs are orphan drugs. Unfortunately, the pharmaceutical industry cued into the value of putting their high cost products behind a gate that limits access to 340B discounts. So more than 90% of these drugs do have an orphan drug designation. It doesn't mean there aren't opportunities for you to access 340B discounts for these products, but it takes somewhat more complex strategies in addition to just opening a specialty pharmacy like Dish hospitals are often doing these days. Um, for health plans, self-funded health plans in particular, a really common and really effective strategy is to establish incentives and mandates so that your employees and their dependents using your benefits choose your pharmacy. When you have a pharmacy that's filling your own prescriptions for your own plan, you often save 30% or more on the cost of that drug compared to when it's filled at CVS, Walgreens, or another outside pharmacy location. This chart illustrates the future of specialty pharmacy development. 80% of new drugs approved in 23, and this is also true in 24, were specialty products. And 75% of all the drugs in development are specialty products. And many of these, by the way, are injectable or infused drugs. And so it's important to have access to not just the retail style specialty drug product margin, but also to the margin available for those drugs that are self-injected, clinic injected, or infused products. What we generally recommend is if you have a retail pharmacy, you can expand that pharmacy into capturing specialty pharmacy opportunity. And if you don't have a retail pharmacy, I don't suggest diving directly into specialty pharmacy. We start with a retail pharmacy and grow into specialty over time. There are a fair number of advancements your retail pharmacy operation will need in order to qualify as a specialty pharmacy. That includes technology for patient management, patient communications, workflow, et cetera. It can include physical space for specialty workflow, as well as equipment like refrigerators and freezers and backup power. You'd be surprised at the number of pharmacies I've encountered that don't have backup emergency power, but that is absolutely a critical requirement for pharmacies that store high cost specialty drugs. Specialty pharmacy accreditation is necessary to access some drugs that have limited distribution. And it also is important to access limited payer networks. So I mentioned in the next point that payer contracting to some of these restricted networks is really important in accessing specialty pharmacy revenue, but generally having dual accreditation is a prerequisite for accessing those contracts. And the staffing model for specialty pharmacy dispensing is different. You need clinical pharmacists, prior authorization technicians, and additional staff involved in the dispensing and shipping process because these drugs tend to be more complex. They're often refrigerated. They have to be shipped in boxes by common carrier with cooler packs, et cetera. So the staffing model and investment in that type of infrastructure is also a necessary component of expanding into specialty pharmacy. Building a specialty pharmacy or growing your specialty pharmacy revenue stream can seem like a really daunting and overwhelming prospect. And it can be. It requires a lot of investment, time, energy, capital sometimes to find the space and equipment, et cetera, in order to achieve those specialty pharmacy goals. But there are, at this point, many, many partners out there that can help you through that process in several different ways. The three most common models are consulting models, where you have an expert that walks you through the process, gives you advice and support throughout, while your own team takes on the labor of building a specialty pharmacy and establishing all the policy procedures and the operational capacity, et cetera. There are managed service structures. Some of you may be using a managed service provider for your retail pharmacies now. There are a lot of those organizations that help hospitals do that with specialty pharmacy. It's still your pharmacy. You own it. You get the lion's share of the benefit, but you have a partner that manages it for you. And then there's a hybrid version of that where you outsource certain services. So you may still operate the pharmacy, you're still dispensing the prescriptions, but you have a partner that provides things like patient management, clinical follow-up, and helps you through payer contracting, accreditation, et cetera. These partnerships come in several flavors. A lot of them have gain share models where you pay the partner a proportion of your top line revenue or your margin increase. That can last for 3 to 5 years. Those contract terms can be extended if the partner offers you capital for upfront investment, which several of them will do. So if you need $500,000 or $1 million to build a specialty pharmacy, and your capital situation doesn't allow you to do that in the time frame you'd like to, there are partners out there that will offer that capital for an increased proportion of that revenue and a contract for a longer period of time to repay that capital investment. There are also many consultants and other vendors that will help on flat fees, fixed monthly fees, usually 12 to 24 months, the life of the engagement. Those can range from a couple $1,000s a month to $100,000 a month or more, depending on the scale of the project and the type of services you're getting from those partners. The last section here is emerging strategies. So everyone is interested in AI, and there's a fair amount of AI or automation related technology making its way into the pharmacy and 340B space. Some of them handle that price verification process I mentioned earlier, or referral capture and identifying missed opportunities. There are also vendors and tools out there to do automated auditing and compliance analysis to identify potential areas of diversion. Historically, a lot of 340 programs will have a sampling method where they'll say we're going to look at 30 claims a month and see if we have any instances of non-compliance. These tools can help you look at 100% of all your claim and dispensing activity to identify potential gaps in compliance. Analytics in general, there are a lot of analytics solutions out there that will help you identify performance opportunity. It will give you insight into what you're capturing, what you're missing. In the specialty pharmacy context, one of the most common ones is a leakage report. We look at by location and by provider which specialty prescriptions are not coming to your pharmacy. And that helps us understand why they may not be coming to your pharmacy and helps us formulate strategies around how can we improve our performance in those specific areas. Sometimes it's as easy as talking to a doctor saying, hey, we have a pharmacy, our patients have a great experience here. Other times it's complex and we may need to put a pharmacist or a technician in that clinic to help provide them the support they need so that we can capture those prescriptions. After the Genesis decision, a lot of organizations started finding creative ways to shore up or establish the patient relationship between your organization and providers so that 340B eligibility can be maintained. MTM stands for Medication Therapy Management. That's typically nurse or pharmacist-led. Telehealth encounters are often between providers, whether it's MD, mid-levels, et cetera. We can use those types of encounters the same way we do physical encounters at registered outpatient locations so that we can establish, extend, and preserve the eligibility of our patients. There are also many other benefits of delivering those types of encounters around reducing drug costs, improving adherence and outcomes, avoiding preventable complications, and unnecessary or wasteful medical spending. We have started to see collaborations between critical access hospitals and sole community hospitals and DSH hospitals around the delivery of high-cost drugs so that you can access the discounts that are gated behind that orphan drug exclusion. These relationships are much more common when you have critical access hospitals and sole community hospitals that are part of the same system. But we are starting to see some of those relationships develop between unrelated critical access hospitals and DSH hospitals where care is being jointly delivered by those two organizations so that those medications can be eligible for the DSH hospital and the value of those discounts can be shared with the critical access hospital. That can also have the effect of extending access to specialty care into rural areas that might not otherwise have access to oncology care, rheumatologists, neurologists, headache specialists, et cetera. So there's a lot of value and a lot of activity around that. And health plans, infusion strategies, and patient drug assistance programs are covered on the last few slides. So health plans, we're starting to see a lot of companies pop up helping connect health plans with largely 340B ineligible populations with covered entities and covered entity-owned pharmacies. And the concept here is that through the provision of telehealth services to the members of those plans, the plan can benefit through reduced costs that can also reduce premiums and out-of-pocket costs for plan members and increased 340B revenue and margin for the hospitals and the hospital-owned pharmacies that are dispensing those prescriptions. To think about this and how it would be operationalized, imagine there's a Blue Cross in your state that has 100,000 members in a plan, and only a small fraction of those plan members are currently seeing your providers or coming to your hospital locations. Many of those patients are not otherwise 340B eligible, and the health plan is not benefiting in any way from the 340B discounts that might be possible to obtain for those members. You form a relationship with that health plan that says, for the 5% of patients using the most expensive medications, let's have a telehealth or other encounter between our providers and that patient. Provide them viable medical primary care specialist services that allow us to qualify the prescriptions that those patients are using for 340B, and then the health plan and the hospital and the pharmacy share the benefit of those savings that are obtained. The net effect is it drives down costs for total cost of care for those patients in your state, and it shares the value of those savings between entities that genuinely need it. There's a lot of activity around infusion strategy. I mentioned that most new drugs that are coming out are high cost specialty products, and a growing percentage of those drugs are infused. There's also a lot of pressure on hospitals, as I'm sure many of you have encountered, around hospital-based infusions, a lot of resistance around site of care challenges, denials of authorizations, white bagging demands. Anyone in the pharmacy hates white bagging because it means the drug comes to us in the mail or in a package. We don't know what it was exposed to before it got to us. We don't know where it came from, but we're still expected to infuse it into our patients and take on all that liability. So a strategy that a lot of hospitals and health systems have been developing is to develop some internal competition for hospital-based infusion and to stave off external for-profit competition that's growing around the country. This can look like opening an ambulatory infusion center with separate reimbursement terms with your payers. It can involve establishing ambulatory infusion suites within provider clinics. Infusion, the revenue cycle management demands of infusion can be particularly challenging, especially if you're engaging in home infusion. There are partners out there that will help you do that. There are a lot of folks I've seen start to engage in relationships with contract infusion providers, where a company will come in and help provide access to infusion services. It's still your providers, it's still your nurses, it's still eligible for you, but the revenue cycle management, the formulary selection, the preparation of those drugs, et cetera, is handled by a partner. So there's a lot of potential value in there, and this is a really growing strategy nationwide. And then the last slide here is talking about patient assistance. There are a number of sources of patient assistance out there, but there are unfortunate gaps. So this grid gives you a high-level overview of what many of those sources of assistance are. And as you can see, if you're over 200% of FPL, you don't qualify for Medicaid. You rarely qualify for hospital assistance. A lot of the manufacturer programs don't include you, or you may not be on programs or on drugs that are sponsored by some of those specific manufacturer programs. So we have become really active in encouraging our clients to consider offering their own prescription drug assistance programs. There are a lot of benefits to patients, clearly, in terms of accessing medication, staying on preferred primary therapies, et cetera. But it can also really drive performance in your pharmacies, improve those capture rates, and improve the financial value that your pharmacy or 340 programs overall generate. So I'll pause here. I haven't seen any questions come up, but I'll spend a few minutes answering any questions that people may have. You're also welcome to reach out to me by email or work with Stroudwater or me directly to set up follow-up conversations.
Thanks, Nate. This has been a really informative session, and just want to again encourage people, if you have questions, you can feel free to utilize the Q&A button down in the just right of center of your screen, and we'd be happy to share those. So we'll give folks a few minutes.
Just reviewing the final results of the last poll, 41% of everyone on the call has an in-house pharmacy. 15% have capture rates between 10 and 30%. 45% have capture rates over 50%, and 30% don't know their current capture rates. Really interesting and pretty reflective of what we see out there. I sometimes worry when people report capture rates that are over 50% because there's different ways of measuring capture rates. And, you know, I think it might be even a lot of those cases where you think your pharmacy is performing really well, worth doing a little bit of a dive into the data to make sure you're getting what you think you're getting. But for those of you who are tracking it, it's great to see you're tracking it. And for those of you who aren't yet, I strongly recommend it.
So it looks like we've got a couple of items. Somebody just commented saying, great presentation, very informative. And then we had a question, are other cause seeing that owning a retail pharmacy and the 340B benefit outweighs the negative cost report impact versus contract pharmacy, the contract pharmacy model?
Yeah, great question. There are a lot of critical access hospitals that own retail pharmacies. And in general, the value is really strong. There are considerations to bear in mind if you don't have a retail pharmacy and you're thinking about opening one. If you are in a state that has not passed protective legislation around contract pharmacy access, the most immediate consequence of opening a pharmacy can be losing access to designate external pharmacies within 340B ESP. So that needs to be factored into your business plan. But for critical access that own hospitals that own pharmacies, a lot of them do a great job in filling prescriptions for their own employees under their own employee benefits and save a lot of money that way. It can also help close some really significant gaps to pharmacy access. We've seen a lot of cause that live in pharmacy deserts, where recent, independent pharmacies have closed. Chain pharmacies may be hard to access or out of the way for a lot of the patients that are in our hospital service area. So financially, and in terms of patient care, there are a lot of benefits to having your own pharmacy, and it's the best possible hedge. And I really want to emphasize this against future disruption to 340B. We don't know what will happen in the next 2 or 5 years around access to 340B, but so far there really have been no major developments that have impinged on access to discounts at our own pharmacies. So if you want to be sure that the benefit you get now, you still get most of it in the next 2 or 5 years, having your own pharmacy is probably the best investment that you can make.
Perfect, thank you. It looks like there are no other questions in the chat. So with that, yeah, thanks again, Nate, for sharing the presentation. Hope everybody here enjoyed it. And again, feel free to reach out to Nate or others with any questions if you do have any afterward. Thank you all for attending, and look forward to hopefully staying in touch with you all. So thanks
Thanks
again,
all.
Nate.
Appreciate your time.